نائب قائد نادي جراحة العظام أن أرحب بكم في هذه الجلسة المميزة التي تأتي استكمالا لمحاور دورتنا العلمية، والتي تهدف إلى تعزيز معرفتكم في مجال التصوير الطبي بما يخدم مسيرتكم الأكاديمية والمهنية في التخصصات الصحية المختلفة. موضوعنا لهذا اليوم سيكون التصوير الطبي في جراحة العظام، والذي ستقدمه لنا ضيفتنا المميزة الدكتورة دارين، متخصصة في جراحة أورام العضلات والعظام، ولديها خبرة عميقة في تصحيح التشوهات وإطالة الأطراف وتجميل العظام، حيث ستأخذنا في جولة علمية ثرية حول التطبيقات العملية للتصوير في مجال جراحة العظام. نذكركم كالعادة بأن تسجيل الحضور سيكون في ختام المحاضرة، فنتمنى منكم البقاء معنا حتى النهاية. والآن نترك المجال لدكتورتنا الكريمة الدكتورة دارين. تفضلي مشكورة.
الله يعطيكم العافية، ما قصرتوا، شكرا على الاستضافة. إن شاء الله ما راح أطول عليكم، شوية حنتكلم عن ال images in orthopedic surgery and just I want to give small introduction about me. I was graduated from Al University, then I joined the Saudi Commission for Orthopedic Board in Saudi في Faqih. Then I took Hospital Administration and Service from King Abdulaziz University. I did my first fellowship in King Faisal Hospital and my second fellowship in Australia as a deformity and osseointegration. I'm a consultant oncology nutrition also. And today we will talk about intraoperative imaging, tools and machine, radiation safety, aprons and shield, and pregnancy in orthopedic, the new guidelines, radiology reports, communication between radiology and surgeon, and overlap tools between orthopedic and radiology, some future innovation and advices in that field. So, images intraoperative, it's a real-time imaging during the procedure, during the surgery, guiding the decision making. It enhances surgical accuracy, reduce complication, and minimize the need for revision. For example, sometime we need images in arthroplasty surgery or in oncology just to prevent malalignment of implant, that prevent future revision if we took an image after the surgery and we found complication. It's improve the patient outcome. The goals is better alignment, precise implant position, safe tumor margin, and minimize minimal invasive technique. So, effect, I just want to talk about shortly of effect of radiation on living tissue. So it's a damage at the cellular level in the living tissues. It rapidly replicates cell components such as DNA and cell membrane are the most susceptible for damage from radiation. This is either direct by damaging the cell directly or indirect by forming a free radicals and that cause continuous damage to the cell. It can cause a disease like cataract for eyes. 85% of papillary carcinoma in thyroid are through radiation induced. Surgeon hand have the greatest exposure risk due to their constant proximity to the radiation beam. So first, image intraoperative, the famous one, the CR, the fluoroscopy. It's a standard in trauma and deformity surgery. It gives us 2D images, widely available and cost effective. The problem with the C-arm is the radiation exposure and its operator dependence. What does it mean operator dependence? That during the surgery, the radiology technician, he aim the beams to take AB, but sometimes we need 30-degree rotation, 30-degree anterior and posterior. So it depends on the technician. Like when we do femur nail and we want a perfect circle, it will take many shots until we reach the perfect circle. That will cause more radiation exposure. So this is the anatomy of the CR. So A is the X-ray tube, B is the image intensifier, C the collimator, D the display monitor. This is in surgery, we position the patient. This has a hip fracture, we position the patient, put the C-arm, take the X-rays. We have a mini C-arm. less radiation used in hand and foot surgeries. Then we have the OR. It's an intraoperative CT, 3D visualization used in spine, pelvis, and complex deformity cases. It's give us the accurate screw placement and navigation integration, high cost, longer operative time, and the radiation dose is very high. We have navigation and robotic system in intraoperative used between CT scans and computer assistant guidance. It's used in pedicle screws and sometimes in rare situation in osteotomy. It's need training and infrastructure and cost justification. Ultrasound, no radiation at all, but it's operator dependent, used mostly in oncology to identify the neurovascular structure and the soft tissue margin. So, radiation safety, why it matter? Orthopedic surgeons are among the highest exposed surgical specialty. Chronic exposure, as we said, increase the risk of cataract, thyroid issue, and malignancy. And we have something called ALARA principle, as low as reasonable achievable. Minimize dose while achieving clinical goals. It focuses on 3 points. The first one, the time. Reduce the fluoroscopy time. Then the distance. Minimize the distance from radiation source. Use the image intensifier side. Shielding, use a protective barrier. So, first point, time and distance. So, we have something called the scattered level. When the radiation come, it hit the object and is scattered everywhere. So, the study said that if the scatter level decrease proportionally to the inverse of the distance square from the X-ray tube, that known as the inverse square law. Okay, what it's mean? By doubling the distance from the X-ray tube, you received only 1/4 of the exposure from the scattered. كل ما بعدنا عن السبيس تبع السكاتر كل ما قلت نسبة إنه البيمز hit us. The highest rate of scatters is produced between the X-ray tube and the patient. Because of this, the X-ray tube is usually positioned underneath the patient. Like here, this is the tube underneath the patient. Underneath the patient. When we turn it, sometime, unfortunately, we need to turn it and use the intensifier as a table for a fracture distal radius. Sometime we use it. And the scatter become more toward the surgeons. Okay. Let's talk about radiation safety. Lead apron. So it should be minimal 0.5 millimeter equivalent. The apron, we should use the thyroid shield, and lead glasses. Okay, this is new. It's 1 week back. It's released by Australian Association about the pregnancy and orthopedic, the guideline when it's come to radiation. Okay, so I will go through the summary fast, just to be familiar with it. They said no. If the first step, if you can change the field, it's recommended or decrease the exposure. But if you can't, like an orthopedic surgeon, exposed pregnant staff member should provide with a personal dose monitor like this one. A fetal dose monitor, two monitor. One at the fetal level should be under the lead gown at the level of the uterus. The other one should be on the chest above the lead gown. And the fetus should not receive more than 1 MSV of fetal radiation over the whole course of pregnancy, not only the first 3 months as the previous research suggested. A lead apron, thyroid shield, and other protective device should meet minimal design criteria. What is the criteria? The apron at least 0.25 thickness. The recommended is 0.5 millimeter thickness. Both, but the guideline said 0.25 millimeter thickness is adequate. Okay, and it should prefer use separated, wrapped around the vest and skirt, no opening in the back with a thyroid shield like this one. No opening in the back, and underneath it another shield protecting the uterus with the thyroid shield. Okay, so they recommend that the pregnant lady should purchase her own lid, because falling down of the lid every time on the floor, it will break the lid from inside. So when she buy her own lid, she will take care of it. All lids should be tested annual, and pregnant workers should consider whether they choose to opt out of minimize intramedullary nailing through their pregnancy to avoid reaching the maximum pregnancy radiation limitation. So the intramedullary nailing, if she can avoid it, it will be best. Otherwise, she can continue with the protection. Any person who is pregnant or potential pregnant has the right to opt out of any procedure involve fluoroscopy. What is the difference between C-arm and fluoroscopy? Fluoroscopy, continuous X-rays for a short time. While C-arm, when we use the C-arm for X-ray, it's shot, one shot. The fluoro is continuous. Radiation dose should be minimized by avoiding continuous fluoroscopy, avoiding the use of magnification of the beam, increase the distance from the beam. For every meter further away from the beam, the dose reduced by half. Okay, so the next step is radiology reporting in guiding surgical decision. What the report should contain, okay? We, as an orthopedic, we love to see in the report the fracture classification if possible. Must an oncology report contain the tumor characteristic like size of the tumor, location of the tumor, the margins, the neurovascular structure, distance from the tumor. In joint pathology, we would like to know the severity of arthritis. If there is a vascular necrosis, what is the stage? The cartilage loss, where is the location of the cartilage loss? In deformity analysis, for me, it must contain mechanical axis deviation, rotational profile, distal angle, proximal angle, joint line angles. In spine pathology, stenosis level, instability grading, pedicle diameter, it's very important. So, benefit of a structured radiology report: improve communication between the radiologist and surgeon, reduce misinterpretation and surgical surprises, aids in multidisciplinary tumor board and planning meeting. As in oncology, we have a multidisciplinary tumor board when the radiology attend and explain to us the images, the size, the margins, the tumor, the neurovascular bundle, explain to us everything, and we keep asking a question that it's not mentioned in the report, just to have a planning, a clear planning for surgery. Facilitate legal documentation and research. What is the common challenges in reporting a non-specific or overly descriptive report without clear impression? Lack of measurement. It's very important, especially in deformity correction. Failure to mention critical details, like there is a small intra-articular extension. This is very important. Sorry, this slide is impacted, but I want to give an example of a good radiology report. So, the study here mentioned, sorry. The study, it's an MRI left distal femur. with contrast. Clinical indication. This is the surgeon should give it to the radiologist. 22 years old, progressive distal thigh pain with a swelling, evaluate for bone tumor and local staging. Okay? Technique. The radiologist mentioned it's a multi-planar, multi-sequence MRI, left distal femur, performed before and after intravenous gadolinium contrast administration. Finding. This is the best report that any oncologist want to read. Location. The lesion is central in metadiaphyseal region of the distal femur, eccentric in position. So the surgeon will know that the metaphysis and diaphysis involved in the tumor. So instead of resection of the diaphyseal, he will think about resection of part of metaphysis just by mentioning its metadiaphyseal region. Measure 8.2, 4.5, 4 centimeter. It's very important because we measure the tumors after resection. We estimate the size of the tumor we will resect based on the MRI, not the X-ray. MRI, based on the MRI. So we plan intraoperative. Sometimes you cannot see when intramedullary tumor, you cannot see outside the bone. You don't expose until the bone, you expose the soft tissue, so you approximate what it's mentioned in the report. It's 8.2 centimeter, so you approximate this is my resection and then take a margin and send it for pathology. If the measurement is accurate, usually the margin will be free. Then it comment on the margin. It's ill-defined with a primitive pattern of bone destruction. It's a malignant tumor. Cortex, cortical breakthrough seen in posterolateral with extraosseous soft tissue extension measure 3.2 centimeter in thickness. That will tell the surgeon, do not expose the bone to remove the tumor with a negative margin. You have to take a soft tissue measure 3.2 centimeter in thickness. Soft tissue component, heterogeneous enhancement with necrotic area, neurovascular bundle is displaced but not encased. That means the neurovascular bundle can be dissected from the tumor. When it's said it's encased, that means the plan change, that we need a vascular surgeon, plastic surgeon to do graft. See, a neurovascular bundle is displaced but not encased. It make a big difference in planning the surgery with other specialty. Periosteal reaction, aggressive sunburst pattern with Codman triangle formation, joint involvement, epiphysis, spur. No intra-articular extension. Immediately, the plan here is extra-articular resection of the tumor because image-wise told us that no intra-articular extension. This is very important. Skip lesion, non-visualize on current study, which is good. That means I don't need to extend my resection or take the patient for palliative care instead of surgical plan. Other finding, no pathological fracture surrounding muscle edema. The next important step in the report is the impression. It suggested osteogenic sarcoma of the distal femur. It gave us a differential diagnosis. Recommendation CT chest. It's important to mention a recommendation CT chest for pulmonary metastasis. Biopsy. He recommend a core needle biopsy, posterolateral approach, surgical incision to avoid contamination of an involved compartment. Here, usually, we call the radiology before the biopsy and we tell them, look, my approach is a posterolateral, for example, posterolateral approach. So you take the biopsy through a posterolateral approach. Here, the communication is very important. Multidisciplinary tumor board review for neoadjuvant chemotherapy planning. See, this is the perfect report any surgeon can take. Okay, so let's talk about communication between radiology and orthopedic surgeon. Why communication matter? Imaging is not just diagnostic. It guides surgical plan in approach, in implant, in margin, and sigil line. Miscommunication can lead to wrong surgical approach, wrong implant choice. How the implant choice based on the images? We have templating for arthroplasty based on the X-ray. We have CT scan, we send it to customize an implant for a patient, especially pediatric. So if the image is not good, that means the surgical implant choice will not be good. That means failure to plan is planning to fail. Missed pathology like skip lesion or subtle fracture lines. This is important. Contaminated biopsy tract. The surgeon did not tell the the radiologist that he will go through the medial approach of the femur. And this radiologist, for example, took the biopsy from anterior. It contaminate all the surgical field. It will need plastic surgery to do flap. It will destroy the surgery. Miscommunication just by not talking about the biopsy track. Clear communication ensures timely, accurate, and safe treatment of the patient. Okay. Clear clinical indication. This is a surgeon, which usually the surgeon um, don't give it to the radiology. History, uh, age, symptoms, mechanism of injury, what clinical suspicious for possible osteosarcoma. Clinical question, is there an intra-articular extension? Can you assess neurovascular encasement? This is help radiologists to tailor the protocol and focus on what matters surgical. Structured report, as we said, the good report, the radiologist should use a structured format, indication, techniques, finding, impression, precise measurement, tumor length, screw trajectory, deformity angle, surgical language, mention the compartment, relation to neurovascular bundles. What is the neurovascular bundle that encased in the tumor? Intra-articular extension, fracture classification. The communication, it's a two-way dialogue. A surgeon should call or meet the radiologist. For this is an oncology weekly. I call the radiologist, I visit their office, I put the images, discuss the tumor, where is the best approach, talk to the radiologist to clarification for complex finding, review image together, not just the report. Biopsy planning, approach should be coordinated to avoid contamination of a future flap or resection field. Okay, overlap between radiology and orthopedic. In orthopedic, we use an ultrasound guided injection. It's a real-time visualization. You can see the needle and target structure as you inject. Accuracy, ensure the medication is delivered exact in intended site. Like if we want it to be in the tendon sheath, in the bursa, around the nerve, so we see it. Like different than blind, we go into the joint or to the tendon and we try to move the tendon to check it. The tendon is targeted or like in trigger finger. When we have ultrasound, it will be more accurate. Safety, avoid neurovascular structure, reduce risk of intratendinous injection or accidental injury, which can lead to tendon rupture and tendon tear or laceration. There is no radiation, ideal for pediatric patient, pregnant woman, or in case of repeat procedures. Dynamic assessment, can watch fluid spread in a real time or aspirate fusion under guidance. Joint injection, we have the glenohumeral joint or AC joint. We see the capsule and we inject underneath and in the capsule. We give a steroid or BRB injection. In hip, either intra-articular injection for osteoarthritis or diagnostic block. In the knee, we can give corticosteroid or hyaluronic acid or viscous supplementation in the ankle and subtalar joint. Okay, what about the soft tissue and para-articular? In subacromial bursa, we identify the impingement of the rotator cuff and the inflamed bursa, and we give the injection there. In the trigger finger, we identify the flexor tendon sheath, A1 bully, and we give the injection. In dequervian tenosynovitis, we identify the first dorsal compartment. In the plantar fascia injection or trochanteric bursa, where greater trochanteric identify and the bursa can be seen, we see the needle going into the bursa and we give the injection. Sometimes we do nerve block, femoral nerve, sciatic nerve, suprascapular nerve block for pain relief at the clinic, or aspiration like joint effusion, diagnostic and therapeutic, or in the abscess drainage. So we have, as I said, blind injection, and new is ultrasound guide injection. The accuracy of the ultrasound can reach to 100%, while the blind maximum 70%. Better patient outcome, especially in deep joints like hip, fewer complication, no accidental intratendinous injection, and more cost effective over time due to reduced repeated injection. Okay, future innovation in radiology. It's interesting for me because some of these techniques already emerged in our orthopedic field and radiology, and something is proposed for near future, like artificial intelligence and machine learning, automated image interpretation, AI models detect fracture, dislocation, tumor faster than radiologists in some setting. They are developing software for radiology, still under developing, but it's not uh, uh, we cannot depend on it at this time because of the accuracy. Real-time alerts in ER setting like meniscaphoid fracture or hip fractures. Measurement and planning assistant. Automated cup angle measurement for scoliosis. AI-based templating for arthroplasty. Applications like Bone Ninja, which you can put the X-ray and they do the measurement for you. It's not an artificial intelligence, but it's one of the application emerged in the deformity correction. Predictive analytics like radiomics using imaging feature to predict tumor grade, recurrence risk, fracture healing potential. 3D printing and virtual surgical planning, 3D reconstruction from CT and MRI, produce patient-specific bone models for pre-op planning. We used to do this in King Faisal Hospital. When we do a CT and MRI, they put it in the 3D labs and they print the tumor with the real-time size and the cutting jigs, custom implant. We send it to Germany and they bring us implant based on the normal femur. So the patient will have same measure of the normal femur in the other side. It's only based on the CT and MRI done for the patient, and they custom the jigs, the implant, and trainees can rehearsal surgery on printed bone models. This is an example of 3D printing. This is the fracture, this is the proposed model, and this is the implant. Augmented reality and mixed reality, intraoperative imaging overlay, augmented reality, glasses projecting CT and MRI imaging over surgical field, see-through anatomy for pedicle screw placement for tumor resection. Now there is I think I put an image I will show you. It's like a Google's. You will wear it and you see the CT image while operating on the patient, and so you can correlate the screw position. Virtual surgical navigation, holographic reconstruction guiding osteotomy and implant placing. Now we have robotic surgery in total knee where we put the robots and it's based on the images and give us the slopes, accurate slope, accurate cut, accurate everything. Low dose CT protocols and portable images. They trying to reduce radiation while maintaining imaging quality. Portable imaging device like ultrasound for clinic and bedside, portable wireless mini C-arm with a lower radiation footprint. Now we can see it in clinic, we can see it in operation with low dose of radiation. Fusion imaging and hybrid OR, multimodality fusion, overlying CT, MRI, fluoroscopy for precise navigation, intraoperative MRI suites, teleradiology and cloud packs. Now we are in Riyadh in my hospital. We received a teleradiology report, remote consultation. They have an access to our packs, cloud packs. The radiologist in Jeddah, he write the report and I can see it in Riyadh. For like a specialty that, for example, musculoskeletal oncologist, radiologist, or they are uh, not very common, so they work with a different hospital to do a tele-radiology just to have an access to an excellent radiologist. Okay, so far so good. Questions, or we'll take the question at the end? Okay, so my advices for you. First advice, master the basic of images. During my residency, I bought an MSK images book to read X-ray, CT, MRI sequence, how to do the views, AB lateral obliques. Some of my training was in a hospital that they don't know how to do skyline views, Judate views. So I read it from the book, I apply it with the radiology technician and learn the alignment, learn the measurement in the X-ray. Read. This is a very important knowledge that unfortunately we do not focus on it on during the residency program, is to read in radiology, how to read the images, how to do the views, how to read the MRI. This is one of the books that I recommend, Orthopedic Imaging, a Practical Approach. The second advice, correlate clinical finding with imaging. Always examine the patient first, then look at the image. Do not look at the image, then examine the patient. Do not depend on the radiology report alone. Use your clinical sense. Practice seeing the story. Does the image explain the patient pain, deformity, and limitation? I'll give you an example. This X-ray. When we see this X-ray, it's severe osteoarthritis of the knee. The patient need total knee replacement. But when we saw the patient is thin, non-smoker, active, going to gym, doing swimming, doing squatting without pain, sitting on the ground, praying on the ground. She does not need a total knee replacement because her muscle is strong enough to offload the joints, and she doesn't need a knee replacement. So do not base your judgment on images. Base your judgment on your clinical sense. Images are tools, but not a guide for a decision. It's a tool to guide you, but it's not a guide itself for your decision. Get comfortable reviewing imaging yourself. As a student, look at the images side by side with your senior. Always ask a question. Where exactly the fracture line? How do you know the reduction is acceptable? What are the angles before reduction? What make it surgical angles? What make it conservative angle? What does the non-union look like? Always be curious about the images. Ask questions. See as much as you can images. Don't be shy. Ask questions. Learn the language of radiology. Get familiar with the term like perosteal reaction, lytic sclerotic lesion, intra-articular extension. Understand the fracture classification system. It's important for orthopedic to know like AO classification, Neer, Chasker, Garden, Salter, Harris. They all the language of orthoradiology communication. When I'll tell you why it's important. The consultant at home taking the on-call. So you call him. I have a patient, fell down, fractured distal radius, X-ray showed a distal radius fracture with intra-articular extension. The angle is X and Y, Z, and there is a deformity in dorsal or palmar aspect. The classification, AO classification is this. So the surgeon, without need to see the images, he already know the image in his head, and he can take the decision based on that. Respect the role of radiology in surgery. Radiology isn't just a picture. It guides your incisions, implant, choice, and surgical plan if taken correctly and was well planned. Work with a radiologist, give them good clinical information so they will give you a good report. Sometimes I see some of fellows or residents, they write 35 years old with a fractured tibia. Okay, do you suspect intra-articular extension or no? There was a dislocation before or no? Put the details so the radiology will give you a good report based on your details. Sometimes there are 32 years old female patient without mentioning the fracture. Where is it? So the radiologist, like third toe fracture, they don't write suspected third toe fracture. The radiologist will look at every toe and he will assume that you mentioned the third toe fracture. This is the role of radiation intraoperative. We put the images. I put this slide just to tell you something also. For me, when I plan the tumor, I print the images with the neurovascular bundle, the dimension of the images, I put it in the surgery. Sometimes we have a computer, we put the images. And during the surgery, we keep reviewing the images. What is the nerve distance? Even if we know it, what is the length of the tumor? What is the details? We keep the monitor and do the surgery. We keep watching the images and do the surgery. Practice radiation safety early. Please, please, please do not enter a surgery and say it's one shot. You don't know what's gonna happen. Wear the apron, the thyroid shield. Some hospitals, they don't give a thyroid shield. Buy them. It's not expensive. The glasses, the lead glasses. Stand on the image intensifier side whenever possible. Learn the ALARA principle. Protect yourself and the patient. Use every case as a learning opportunity. In trauma calls, look at all the x-ray yourself, not just the one you are asked about. Chest is clear, see the chest. Maybe someone missed a rib fracture. Spine is clear, check the spine. Maybe someone missed a avulsion fracture, which indicated instability in the spine based on an avulsion. Like, for example, let's frank. Order the standing x-ray, and based on that, you can see the flick, bone flick, which indicated less frank, which indicated instability, which indicated surgery. Some small finding in the images indicated the decision of a surgical intervention for the patient. So review all the images, not only the tibia if you suspected tibia fracture. Review the pelvis, review the spine, review the chest. Compare always the pre-operative and post-operative images. See how the surgery corrected the problem. Keep a personal log of interesting imaging cases. Great for future teaching or example. For me, I have up until today, up until tomorrow, up until next year, I will have my logbook. I put the x-rays, I write my finding, what I found, and I saw intraoperative correlated to the images, CT and MRI, and what we did the surgery and post-operative x-ray. This is, you will have a book containing a lot of case studies. You can come back always when you have a similar case. You say, okay, that case, for example, I saw in the MRI, the tumor was not encased, but there was an enhancement. In this case, I can see the enhancement. So I should be extra cautious this time. It will be a learning process. Be curious about the new technique. I used to go to the 3D printing lab and see how they plan it and printing it. Navigation screens, intraoperative floor of views. Follow the update in artificial intelligent 3D printing. This will standards tool in your practice. The artificial intelligence, either we like it or we don't like it, it's coming into the medicine and it will replace a lot of basic tools, not persons, tools we use, and it will help us to be better doctors. Learn to communicate well. When presenting a case, describe imaging finding clearly and concisely. This is an AB pelvis X-ray showing a displace, comminuted acetabular fracture with posterior wall involvement. Do not just say a fracture is there. Show your understanding of key point. In oncology, for example, we have this. This is a pathological fracture, a well-defined sclerotic borders with a geographic bone destruction. There is no soft tissue mass. There is a periosteal reaction forming of a new periosteal which look benign, not a Codman triangle, which may indicate all this a benign features. Differential diagnosis is 1, 2, 3, 4. It's a systematic in oncology. You have to mention 7 things in images when it's come to oncology. You, with the trauma, you have to mention, is it intraarticular extension? Is it angulated? Is it displaced? What is the classification? Always learn how to read the images. Build the habit of thinking like a surgeon. As a student, when you see an image, ask yourself, so in this image, how to read it? First, read the image. Then ask yourself, what is the best surgery? I will do open reduction internal fixation for distal radius fracture. What I will put? T-plate, for example, distal radius plate. What complication should I watch for? Radial artery, median nerve, flexor tendons. What approach I will open? Dorsal or palmar approach. What is the length of the incision? Plan the surgery as if you're gonna operate on the patient. Once you get the chance to operate on a patient, you already will plan the surgery. uh, this is my talk today. I didn't want to put a lot of information and I want us to have a discussion. So please ask your questions. Let's see what you have questions. Good lead apron. Well, I don't know a company by its name, but the best you should see better than the company, the characteristic of the apron. The thickness should be 0.5 millimeter or 0.25 millimeter. What type of the lid? Is it coming with a thyroid gown, thyroid shield, sorry? The gown should not be open from back as possible. Skirt and jacket is the best. For pregnant lady, they should add the uterus apron. Contamination biopsy tract. Okay. Um, uh, okay. So contamination biopsy tract. When we take a biopsy, and there is two ways to taking biopsy. The first one, it's an it's an orthopedic intraoperative biopsy. When it's performed by non-oncological surgeon, the surgeon, the orthopedic surgeon who gonna perform the final surgery, they will open in a certain approaches. Like the tumor is going medial and the neurovascular bundle is medial. So I will open medial. I will remove the skin. I will remove the tumor. Imagine this is the plan. Someone take the biopsy anterior. Because in their mind it's easy access. This contaminate all the surgical field. That means you need to resect the biopsy tract anterior and the tumor is medial, so you will need to resect all this skin. It will leave a gap and the area of contamination, the anterior contamination, should be removed. So all this area will be empty. You will need a flap, not only graft, unfortunately. This is when performed in surgery. When it performed by the radiology, 90%, 95% of the radiologists I work with, they know the surgical approaches in orthopedic oncology. They read about it. So some small percentage, they will prefer to take the biopsy, as I said, for example, anterior, because in their mind, it's easy access. While the vascular bundle, it's medial. The resection will be medial. That means we will remove all the area. This is can be contaminated. Contaminated not mean by the infection, by spread of the tumor cells, by wrong access to the tumor. Again, if the tumor medial and the biopsy taking anterior, the tumor spread anterior, not only medial. So all this anterior to medial is contaminated by the tumor cell that all need be resected. While the tumor is medial, the biopsy is medial, there is no contamination anterior, we can keep the anterior compartment and we resect the medial only compartment. The closure will be easier and might need a graft, not a flap. I hope it's clear. I don't know how many centers. Uh, okay, a good question. A risk. So, the first 3 months, it's recommended, but because of pregnancy, you cannot perform a research on them. So, it's a theoretical. The first 3 months, it is recommended for every pregnant lady to avoid radiation because of the risk is very high. The risk reduced in the second and third trimester, but according to the new guideline, it should not exceed when the strength of total is by the monitor during the whole pregnancy, not only the first trimester. Once it's reached, stop exposure at all. Not to wear an extra apron or new, stop exposure. So previously it said the only first trimester should be avoided. Now it said during all the pregnancy we should measure the exposure because there is no live tested object to measure that the carcinogenic effect. It's all theoretical, and it's now measuring all the pregnancy, not only the first trimester. And the first line in the recommendation was, if you can avoid radiation during pregnancy, try your best to avoid or minimize by avoiding intramedullary nails, by avoiding turning the C-arm, by taking a distance, wearing the aprons, all this measure to decrease the exposure. Some of my colleagues during the residency got pregnant and they decided to do sport, arthroplasty, and other specialty. The guideline, if you'd like, I will send it to you. Also mention the cement exposure in the surgery, chemical exposure, alcohol exposure. Uh, I can send you the guideline. It's detailed what should pregnant lady avoid during pregnancy. For me, I think once you take the radiology, the question is, which year do you recommend that I start learning and getting more familiar with radiology images? Once you take radiology or orthopedic course, I'd recommend to buy. There is a booklet, small box. I can share it with you later. Send me an email. I can send you the name of the booklet. It's a very small. Tell you how to do AB, how to do the lateral, how to do the skyline view, how to read the X-ray for the knee, for the most common joint. Start with this booklet, small box. When you join the residency program as an orthopedic, the radiology, they have their own books, but as an orthopedic, I recommend to buy a reference book, one book about X-rays, um, CTs, MRI, how to read it. Um, I have a very good reference box. I read it, one of them that I bought in the presentation. And I use not to read it every day a chapter. No. Today I saw a tibia fracture and we did a CT for that. I open an X-ray of the tibia. I read it, how to do it, the position, how to read the X-ray, what is the classification, how to read the CT, how to detect intra-articular. So case by case. When I went to the oncology rotation, I did the MRI reading of the tumors and X-ray reading of the tumors because it's different. So make it case by case. After you start radiology or orthopedic course, start with the booklets in the residency, buy a reference book, read the book during the 5 years. Yes, contamination by tumor cell. Sure, I will send you the guidelines. I'll send you the box. This is my email. Please do not hesitate to contact me about orthopedic, about radiation safety, about anything. Just feel free to contact me for anything. Um, we having coming a mentorship clinic for free, and we having uh, I personally do it. Whatever you have a question about orthopedic, anything in orthopedic, please contact me. And إن شاء الله ما أكون طفشتكم بالموضوع شوية. الموضوع كده مختلف. الواحد ما يعرف أهمية الراديولوجي إلا لما نوصل R3 R4. لما يبدأ يدخل سب سبيشاليتي يبدأ يتعلم الشولدر. A patient يحط MRI without report, you have to read it. Oncology, even with the report, you have to read the images. When trauma, it's easy, but when it's come to subspecialty, it's complicated. So learn early better than learn late. والله يوفقكم إن شاء الله.
في الختام نتوجه بجزيل الشكر للدكتورة دارين على تلبية الدعوة ومشاركتها القيمة معنا هذا اليوم. الله يعطيك العافية دكتورة، ما قصرتي.
الله يحفظكم يا رب، تحت
وش
أمركم أي وقت.
والشكر موصول لكم جميعا على حضوركم وتفاعلكم. كما نثمن جهود نادي جراحة العظام ونادي الأشعة على التنظيم المميز لهذه الدورة. كان معاكم عادل الزهراني منسق الجلسة. نلقاكم بإذن الله في اللقاء القادم، ونسعد دائما بمتابعتكم. ولا تنسون ترى ارسلنا الرابط حق التسجيل، حق تسجيل الحضور عشان تاخذوا الشهاده حقت الحضور. ونشوفكم إن شاء الله في اللقاء القادم. يعطيك العافية دكتورة.
الله يحفظكم. في أمان الله.